Assalamu alaikum. My name is Mahita and my roll number is BP1650118. Topic of my presentation is Cytabarine, which is also known as Ara-C or cytosine arabinoside. It is an anti-cancer drug. It is an S-phase specific anti-metabolite drug which is used mostly in acute myeloid leukemia, and it is single most effective agent for the induction of remission therapies. Mechanism of action: RSC transported by carrier mediated process as that of physiological nucleoside. It is converted to active form, that is ARA-CMP, which reacts with deoxynucleotide kinase to form diphosphate and triphosphates. It then competes with physiological substrate and incorporates to DNA. Incorporated ARA-CMP residue is a potent inhibitor of DNA polymerase, both in replication and repair synthesis, and it further blocks the elongation of nascent DNA molecule. Continuous inhibition of DNA synthesis for a duration equivalent to at least one cell cycle or 24 hours is necessary to expose most tumor cells during the S or DNA synthetic phase of the cycle. Indication or rational use: it is used in different types of cancers, such as in the induction and maintenance of remission in acute myelocytic leukemia. It is also useful in the treatment of other leukemias, such as acute lymphocytic leukemia, chronic myeloid leukemia in blast phase, and high-grade lymphomas. Because the drug concentration in plasma rapidly falls below the level needed to saturate transport and intercellular activation, high doses regimens are scheduled by clinicians to achieve 20 to 50 times higher serum levels with improved result in remission, induction, and consolidation for acute myelocytic leukemia and acute lymphocytic leukemia. Dosing and administration. Route of administration of cytarabine are intravenous, subcutaneous, and intrathecal. It is not available orally. Dose 0.5 to 5 milligram per kg body weight intravenously or subcutaneously for 7 days, or 100 milligram per meter square IV every 12 hours. For meningeal leukemia, 30 milligram per meter square IT Q4 days until CSF finding normalize, and one extra dose after that. Basically, two dosage schedules are recommended for the administration of cytarabine. One is rapid IV infusion of 100 milligram per meter square every 12 hours for 5 to 7 days, or continuous IV infusion of 100 to 200 milligram per meter square per day for 5 to 7 days. In general, children tolerate higher doses than adults. Intrathecal doses of 30 milligram per meter square every 4 days have been used to treat meningeal or lymphomatous leukemia. The intrathecal administration of 50 milligram is for adult and 35 milligram for children of liposomal cytarabine every 2 weeks seems equally effective as the every 4-day regimens with the standard drug. Alternate brands. For different types of brands are available for cytarabine. From economical point of view, the drug Alizan and Cytarine having same price and are cheaper than Cytosar, for which a 100 milligram vial costs rupees 180.03, and for the drugs Alizan and Cytarine, the same 100 milligram vial cost 150 rupees. These are available in sterile powder form and are reconstituted using sterile water for injection or dextrose 5% water and normal saline solution. Alternate drug, gemcitabine. It is a fluorine substituted analog and it inhibits DNA synthesis. It is a broad spectrum drug and can also be used for solid tumors and hematologic malignancies. Adverse effects, most important adverse effects include myelosuppression with neutropenia, thrombocytopenia, cerebral ataxia, thrombophlebitis, mucositis, neurotoxicity with higher doses. Drug interaction. Cytarabine, when given with digoxin, it will decrease the serum concentration of digoxin. Therefore, monitoring of digoxin level is required. When cytarabine is given with other chemotherapeutic drugs, they can cause severe bone marrow depletion. Therefore, monitoring of blood cell count is required. Cytarabine also decreases efficacy of gentamicin by decreasing the susceptibility of Klebsiella pneumoniae. Monitoring of complete blood count, renal and hepatic function, CNS toxicity is required while administering cytarabine. Contraindication, it is contraindicated in pregnancy as it is a pregnancy category D drug, and it is also contraindicated to hypersensitive individuals. Irrational use, high dose of cytarabine in combination with cyclophosphamide when used for bone marrow transplant preparations, it can cause cardiomyopathy, which can result in death of the person. Toxicity, it can produce acute severe leukopenia, thrombocytopenia, and anemia. It can also cause GI disturbances, stomatitis, dermatitis. RSC, either free drug or the liposomal preparation, may cause cerebellar toxicity, including seizures, delirium, myelopathy, or it can cause coma as well. When given with high doses of methotrexate, chances of cerebral toxicity is even high. There could be onset of dyspnea, fever, pulmonary infiltrates on chest CT scan after giving 1 to 2 week high dose of RSC, and it could be fatal in 10 to 20% of the patients. Case study. JM is a 3-year-old girl who is alert, interactive, well-developed, but ill-appearing child brought to the pediatric clinic by her parents, who report that the past week she has been quite fatigued and has had fevers, easy bruising, and puffiness of the extremities. Up to date on immunization, no prior surgeries or serious medical problems, no family history of cancer, but they reside near a site with a history of radioactive contamination. Her vital signs are mentioned along with the lab reports. The aim is to identify the patient's drug therapy and disease-related problems during the course of treatment and what precautions must be observed to avoid severe drug toxicity. Soap notes. Subjective. Gender female, age 3 years. Chief complaint fatigue and low grade fever. Medical history up to date on immunization, no prior surgeries or serious medical problems, no family history of cancers, but reside near a site with a history of radioactive contamination. Objective vital signs shows blood pressure 130 to 83. Pulse is 95, respiratory rate 34, temperature is 36.8. Laboratory data shows hemoglobin 5.7 gram per deciliter, which is decreased, and chest X-ray shows normal chest with no mediastinal mass noted. Lung and thorax examination shows CTA bilaterally without wheezes or crackles, and there is good air movement throughout. Abdomen examination shows soft and non-tender abdomen without distension. There are good bowel sounds and no masses are present. BM aspirate, bone marrow aspirate, shows that 90% blast cells, 30% erythroid precursors, 2% lymphoid, 2% metamyelocyte, 1% promyelocyte, 2% myelocyte. DNA index is 1.4, and early pre-B cell acute lymphocytic leukemia with L1 morphology. TEL AML1 fusion transcript is positive, which is shown by RQ-PCR test, and neuro examination shows that hearing is intact, motor examination shows normal muscle tone and bulk, gait is essentially normal, DTRs are normal, general muscle strength is symmetric and normal, facial strength appears symmetric and normal. Assessment. BM aspiration test and other test results shows that the patient is having acute lymphocytic leukemia with pancytopenia and replacement of normal bone marrow elements. The patient was admitted to the pediatric subacute care unit. Medications and treatment on admission includes the following. Day 1, 1 unit irradiated filtered platelets, 1 unit of packed RBCs, 5% dextrose and 0.2% sodium chloride IV with 30 MEq sodium bicarbonate per liter at 200 ml per meter square per day, and allopurinol 50 milligram per oral TID. There is different phases for chemotherapy. For treatment of chemotherapy, different classes of drugs are given in combination regimens in different phases in proper scheduled manner. First phase is induction therapy. In this case, chemotherapy is initiated at day 2 of hospitalization, and starting with vincristine 1 milligram IV q week into 4 on day 1, 8, 15, and 22. Dexamethasone 2 milligram per oral in the morning and 1.5 milligram in evening, and multiply by 28 days. Pegylated aspergillase 1500 units IM on chemotherapy day 3. Intrathecal therapy with methotrexate, that is 12 milligram on chemotherapy day 1 and day 15. 4 hours after first day chemotherapy, she developed moderate nausea and vomiting with 4 vomiting episodes. Patient also developed a fever of 39.5 degrees centigrade on day 2, and for which antibiotic therapy with cefepime 50 milligram per kg IV Q8 hour is initiated. Plan. She is scheduled to receive day 22 chemotherapy in 2 days, and orders are written to continue chemotherapy on the current schedule. After completion of induction therapy and resolution of her acute illness, she entered in an initial consolidation phase, which is for 4 weeks, that consists of weekly vincristine, daily mercaptopurine, dose of pegylated asparaginase, 3 weekly treatment with intrathecal methotrexate. This phase of therapy was well tolerated, and she proceeded to intensified consolidation phase. This is the next phase, which consists of the following drugs that include mercaptopurine, cyclophosphamide, cytarabine, vincristine, and intrathecal methotrexate. Mercaptopurine is given orally, while the other drugs like cyclophosphamide, cytarabine, and vincristine are intravenous, and methotrexate is given intrathecally. Phases of chemotherapy mostly includes consolidation phase. Additional phases of therapies are interim maintenance, that is non-myelosuppression chemotherapy. Before every chemotherapy schedule of drugs that are causing causing myelosuppressions or are more severe myelosuppression, blood cell count is required. If the patient is having less cell count, then non-myelosuppression drugs are given. and after that augmented interim maintenance, and after that standard delayed intensification phases started. In this case, after completion, the intensified consolidation phase plan is to give additional phases, and that includes interim maintenance for 8 weeks, augmented interim maintenance for 6 weeks, extended delayed intensification for 6 weeks, augmented delayed intensification for 8 weeks, and after that, a second augmented interim maintenance 6 weeks, and a second augmented delayed intensification for 8 weeks is recommended for this patient. The course of the therapy that will be begin on week 30 composed of the following drugs like dexamethasone 10 milligram per meter square per oral. It is in the divided form, that is divided in BID on day 1 till day 21. Doxorubicin 25 milligram per meter square IV on days 1, 8 and 15. Pegylated asparaginase 2500 units per meter square intramuscular on day 4, 5 or 6. Vincristine 1.5 milligram per meter square IV, one dose on week 1 and week 8 and week 15. Methotrexate 12 milligram IT on days 1 and 29. Cyclophosphamide 1 gram per meter square IV and one dose on day 29. Cytarabine 75 milligram per meter square IV daily, 4 days on days 29 to 32, 36 to 39. And the last is thiogonine, which is 60 milligram per meter square per oral on days 29 to 42. References. And thank you.